Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And you know, we've had some comments about something which is most people who are going to be watching and viewing may not be aware of it, but we're going to make you aware of it through this program. And it relates to female pelvic floor disorders and incontinence. Incontinence, we get a lot of questions. I know it's a subject that's sensitive, but that's what we're here for. So let me introduce to you two experts. Dr. Jeffrey Schachar, who is a urogynecologist, and he's got all kinds of acronyms after his name, and I'm not going to tell you what it is. He's going to tell you what it is. So welcome, Doctor.
Thank you very much, Dr. Lippman. Thank you for having me.
Good to have you. And someone who's special, because we just spoke about this, not too many people that are specializing in your field of physical therapy. Danielle Marie, she's got a master's in physical therapy and a lot of acronyms after your name. And you are certified to do an achievement, which is a certification for pelvic physical therapy.
Correct.
And a lot of people would say that this is a female pelvic problem, but I can tell you, as we discussed before, that it is multifaceted. You got male and female. Welcome.
Thank you very much.
Good to have you.
Thank you for having me.
You both practice at Westside and Plantation General, Westside Medical Center.
Yes.
You're located in the medical office building next to Westside Regional.
Correct.
And you are?
Directly in the building on the
Same
second
thing.
floor.
Right.
Mhm.
Okay. Just in case people want to know where you are. Okay, Dr. Schachar, tell me, what's the problem now with many of the patients that come in? We don't necessarily only talk about the pelvic floor issues, but I know that you do a lot of work with robotic and minimally invasive surgical techniques, and these folks out here, that's probably next to the issue of cancer and heart disease, is the most requested area of medical care that we get comments on. So it's all in your hands.
So the two most common things that I treat are urinary incontinence and pelvic organ prolapse. So for pelvic organ prolapse, it's when some of the organs inside the pelvis tend to drop down into the vagina. So either the bladder, the bowel, or the uterus can drop into the vagina, causing sensations of bulge or discomfort. And for those, there are different options, reconstructive options, as far as how to fix that. And so we do minimally invasive surgery, either using the robot and going through the abdomen with small incisions, or actually you can go vaginally and reconstruct everything just through the vagina with no incisions on the belly at all.
And as far as the issue of the pelvic floor itself, sometimes you don't use a surgical technique.
That's correct.
You refer to Danielle.
Yes, so before any surgery, we'd always recommend conservative therapies, and usually that's where our physical therapists come in handy.
Okay, Danielle Marie, talk to us.
I'm usually the first line of defense. So if they come to me, they are, well, sometimes they have issues for quite some time before they even signify to the doctor that they have an issue. So we're talking 2-3 years that they might keep it hidden in secret before they will discuss it with the doctor, because it is embarrassing to them. So I will tell them, and I urge them, that they should, as soon as they have signs of either urgency or not being able to empty your bladder or frequency, overactive bladder, should directly go to the doctor immediately so that they can get the problem and get the script to us so that we can start addressing the problem as soon as possible. The sooner the better. If it doesn't get better, it gets worse. So the quicker we address the problem, the better off they are.
Yeah, of course, again, not to take away from Dr. Schachar's area of expertise, but a lot of the pelvic floor issues also relate to the emptying of the bowel.
Well, the pelvic floor encompasses both, it's
Right.
the saddle, so it attaches at the pubic bone and at the tailbone, so it's kind of like a hammock.
Right.
And inside that hammock, it suspends, like the doctor was saying, the uterus for the female, the rectum, the bladder, so it does drop and it does have weakness, as we age and with other things that can make it weak. So with that being said, you really should address it early on.
Who would think that that if an individual cannot evacuate from the bowel, that it related to the pelvic floor?
Well, like I was saying, inside that muscle is the sphincter for the urethra and for the rectum. So if one part is not functioning properly, soon is the back end will start having issues as well.
Those are the people that really need to be referred to someone like yourself, a urogynecological specialist, correct?
That's correct, yes. Unfortunately, a lot of people suffer with this in silence because they are embarrassed about it, or if they've been told it's normal with aging, or and they're just not really aware that there are treatment options. That kind of, it's just something they're supposed to be dealing with when it can really have a devastating impact on their quality of life. And so it's important for them to know that they should come in and see somebody, because there are things that we can do about it so that they can either completely get rid of their products that they're using or use far less of them.
I would assume that not dealing with it would cause a lot of urologic problems, including infections, the creation of I don't know, you don't create stones, kidney stones, but not being able to empty the bladder does, by at least some indication, causes the buildup of the calcium oxalate or things of that nature that then create stones. Is that true?
Yeah, well, I mean, if it's not dealt with, people can certainly have issues with urinary tract infections. Sometimes just a leakage of urine and constantly sitting in a wet pad or liner, that it can certainly cause infections in the vaginal area. And as far as stones, it's if you're not emptying your bladder well, you can certainly have a backup where it can head towards the kidneys and come back to your kidneys well. So it's important to make sure that your urinary tract is functioning the way it's supposed to be.
Well, give me the sort of the rundown of the age variance of the people who seek your service.
So the truth is that the age range is quite large. It's basically anyone from 20 and up, I would say, is most commonly. Right. Most of my patients are typically over the age of 40, but certainly, there are women under the age between 20 and 40, about 5 to 10%, who do have urinary incontinence issues, especially if they've had prior, vaginal deliveries. And so it's something that most people assume is an issue with older populations, but certainly there are many women in those younger age ranges who do suffer from similar issues.
And the same thing with you, Danielle, if you don't mind me calling you Danielle. What is the I guess you could say, the census of your type of care? I mean, does it come the same way?
It's pretty much the same. It's 18 to 88. We treat them all, and they have similar outcomes, which is really good. So I see the 18-year-olds benefit within a month. They're being able to run again. They're being able to return to their lifestyles without leaking. Their boot camp, and they have really heavy running exercises, which is not the best for the pelvic floor, but it does cause incontinence in some cases. But, the 88-year-olds, you have the people but they do still have similar outcomes, which is, it's good for them.
It really is very, very, very involved. True, doctor?
Very much so, yeah. So when we do our fellowship is a combination of urology and GYN and colorectal, because all the pelvic muscles and all the organs are really very closely related. So when you have one issue in one area, you can certainly have an issue in the other areas. So it's important to have someone and go see someone who's knowledgeable about the whole pelvis in its entirety and not just one part and the other.
Well, like I said, most of the comments, most of the requests that we got related to incontinence. I mean, we get that. It's a tough subject for someone, but they write to us or send us emails, and of course we obviously keep it, insecure comment. We never relate to any individual who talks to us, but it's really sort of devastating psychologically to many of particularly the females that communicate with us through this method. It's devastating to them. I'm sure that they're ashamed, and they think that they've lost their youth. Is that sort of, did I hit on it?
Absolutely, yeah. Many women are very reluctant to talk about it, and they're very ashamed of it because, it happens sometimes at very inopportune times where they'll all of a sudden leak some urine. And for some women, it's just a small amount, and for other women, it can be a very large leakage of urine. And so if they're wearing their suit pants or they're at work or they're in a social situation and all of a sudden they pick up and they have to leave what they were doing, and some of them will even, just to avoid that situation altogether, sometimes will just stay home and avoid those social interactions.
Yeah. Well, tell me, Danielle, Marie, I'm sure that the answer is the same, but do you have anything to add to that?
Just as a case study, I have a family member who waited 2 years in which to talk about her problem, and it started out urinary and then it turned into fecal incontinence. So she had the best of both worlds. So I had to address both of them, and I urged her to see a doctor. So it took her almost 2 years, and I said, I do this for a living, and she still was reluctant to come in. But she said she would be at Walmart and she would be a full cart of groceries, and she said I'd had to leave them, Danielle, because I'd already had an accident. So it really has an impact on people's lives. She doesn't want to leave the house. Most of my 2 o'clock time slots are filled because most people want the mornings for their bathrooming. So they really don't want to come in early because they want to make sure that their toileting and all their issues with their bathroom are taken care of before they come see me. So it really runs your life, and it's not a way to live, especially in your 40s, 50s, and even in your 60s and 70s. It's not a way to live. They don't go on vacation. They don't do things that are important to them anymore. And when she came to see me, within a week and a half, she said, Danielle, I don't want to toot your horn or anything, but I can get to the bathroom, pull my pants down, and sit down, and then go to the bathroom. Whereas before, I was already going while I'm walking to the bathroom. So there's improvement, and it's quick. And that's what's so rewarding. I'm sure the doctor would agree with me that you do see improvement, and you give them their life back.
Well, that's terrific. Okay, Dr. Schachar, talk to me about your robotic and minimally invasive capabilities. I mean, I know you're extremely well trained, but these folks out here are so interested in minimally invasive techniques. And you know why? I mean, when you talk about surgery to the general public, there's a couple of things that come to mind. First of all, it's cutting. Second of all, it's blood. Third of all, it's pain. So they avoid communicating a lot, or they put off some of the required, or I should say, suggested health opportunities or procedures because they think of surgery in that light. But they're very interested in minimally invasive techniques. So let's talk about it.
So minimally invasive refers to any procedure that's not done in the traditional open technique or a large incision. So that's both the abdominal route, which going laparoscopically or using the robot to perform a complex procedure inside the abdomen using very small incisions. But minimally invasive also includes vaginal surgery, which avoids any incisions on the abdomen whatsoever, and everything can just be done vaginally. And the importance of minimally invasive surgery are that people typically will go home faster. Most of my procedures, they either go home the same day or the following morning, faster recoveries, less blood loss, and less complications. So minimally invasive is a very important tool that we have to help people not only get the surgery that they need done, but also recover faster and get back to their lives.
Knowing that people always think of, when they think of you're a urogynecologist, but is there a counterpart that is available to the male species when there are issues related to incontinence as well as emptying of the bowel?
So to become a urogynecologist, you can either start as a board-certified OBGYN or a board-certified urologist, and then do subspecialty training in the field of urogynecology. So for some people who start out as urologists and go into urogynecology, sometimes they will deal more commonly with male issues. As far as both the dealing with the bladder and the bowel issues, we certainly, for females, I can work with them on that, and sometimes I'll work with them in conjunction with a colorectal surgeon.
I'd say. Well, the reason I say is because, as I was saying to Danielle before the show, which I very rarely talk to any of the guests before the show, but the minute I saw her, that she was involved with pelvic physical therapy, I in my own head, I knew that we only had such a few number of certified individuals in that field that we got to talk about the issue of not only female, but male. True?
Very true. I have a good mix of both female and male patients.
And
I see a lot of prostatectomies, and they have excellent results. They go from wearing 12 diapers on the onset to down to 1 pad within a month. So and I have a lot of colorectal issues, chronic constipation, fecal incontinence, anal pain that I address as well. So it's a good mix, and that's my male patients.
The reason why it's so important, and you tell me, is because, and both of you can just jump in on this, is that in both the male and the female, if you're not getting bowel evacuation and you're straining, you cause other problems.
Absolutely. So even for people with constipation who are constantly straining, that's certainly she was saying, well, can weaken the pelvic floor, and which is a lot of times is one of the reasons why some people come in with prolapse, where all of a sudden their rectum is now pushing into the vagina. It's almost herniating through and pushing down on the vagina. It's the reason, so those people who have, and other issues like chronic cough, people with asthma or smokers, tend to have a lot of repetitive increased intra-abdominal pressure activities where they're pushing down the pelvic floor and causing a lot of these issues. In addition, for people with incontinence, if their constipation, and if their constipation is not treated, the constipation can also worsen their urinary incontinence. So treating the constipation and the colorectal side of it is important in fixing the bladder side as well.
And again, just as something came from one of our viewers, and I didn't really know until you just discussed it. They were talking about inguinal hernias. Is that part of the situation? Do you create an inguinal hernia based upon the straining? Does that happen?
So the inguinal hernia is not something that I treat, but it is certainly related to increased abdominal pressure or exercise and things like that can weaken connective tissue, which causes the intra-abdominal contents to push their way out.
I just wondered.
I usually don't address that.
No, I'm just wondering.
I'm sure any type of pressure
we got
you
the
have.
question, and I just listening to both of you and seeing how you're discussing the entire system. It would seem to me that again, I'm not the professionals. You're the professionals. I'm just the guy sitting here trying to ask questions.
It's all interrelated.
And I'm just saying that, somebody asked a question about inguinal hernias, and I said, what does that have to do with it? But then I just realized as we were talking that there's a possibility that you could create this inguinal hernia, as you just said.
Right. Any sort of chronic stress can weaken and impact
your
muscles and your connective tissues.
Well, so both of you work at Westside Medical Center, and I see, Doctor, you're obviously at Plantation as well.
That's correct.
Plantation still has probably one of the largest needs for gynecological care in all of Broward County. I don't know right now whether they're still birthing as many people as they have over the number of years that they were there, have been there, but. Of course, that'll all be here, moved to the new hospital on NSU campus here. Everybody asks, they see all these cranes and they wonder, what's happening here? Are you building new academic buildings? And of course, because they don't get to see the signage. But it's going to be a very, very unique hospital site and operation relative to their care. It's going to be top of the line, up-to-date equipment, et cetera, and of course, we don't in any way denigrate any of our sister hospital corporations or entities, because we have a wonderful relationship with all of them. But it's going to be sitting here, right here. So even though it's not part of NSU, it's sitting technically on NSU land, which was bought by HCA. So you're going to be, hop, skip, and a jump, as they say, away. So again, talk to me, Danielle, about are there new methods, or it's just the application of your subspecialty?
Well, I mainly use biofeedback, which is a very gentle approach to training people how to use their Kegel muscle, the pelvic floor muscle. A lot of people do the exercise improperly. Even I have yoga instructors come see me and they think they know where all their muscles are. It's really a difficult muscle for people to know and to acknowledge that some people don't even acknowledge they have a muscle there. So it's kind of like an uphill battle, because I have to first show them the anatomy. I have to let them know where we're focusing on when we're doing the actual exercise. So the biofeedback machine is an external sensor that I attach to their undercarriage, and you can see up on the screen on the monitor if you're doing the exercise properly. So you don't want to use your stomach muscles, your legs, or your buttocks to assist in the exercise, because then you won't be there. The efficacy is not there. So you really want to hone in on that one muscle so that the problem can be resolved quicker instead of spinning your wheels.
So in essence, you're teaching, in quotes, but instructing, which is teaching, your patient how to apply your knowledge to that particular muscle to raise the pelvic floor.
To strengthen it.
Strengthen it, therefore.
And conversely, I have patients that they come in, I hook the biofeedback to them, and they are tense. They're spasming, just sitting there.
Right.
So, we measure the strength in microvolts. So they could be sitting there and they'll be at 20 microvolts.
Right.
And I'm like, do you feel tense? No, I'm fine. So, they don't even realize that they're having spasms. So they wonder why they can't defecate. They wonder why they're having problems eliminating. They're holding urine in. These are things that they weren't even aware of, that they were tense. So my job is to teach them the reverse Kegel. So it's a double-edged sword. It could either work for you or work for another person in a different manner.
And I assume, since you have Dr. Schachar here, that there's a symbiotic relationship.
He would write a prescription for me.
Right.
And we would designate the plan of care according to the patient.
Right. And then there's a collegial communication.
We work in tandem.
Absolutely.
Correct?
Stronger muscles is good for everybody.
Strong muscle.
And even after surgery, sometimes they'll do, the sling procedure or something, and they need additional therapy to keep it and maintain it.
Right.
So it's just as important. You just don't do the sling and then forget about it.
Well, that's what I was wondering. I was wondering, even though he might do a surgical intervention, as nice and easy as the people would like it to be, you're going to find an opportunity. I was going to ask you whether the surgery is the end, and sometimes it isn't the end. Sometimes it ends up back with you to do the physical therapy, correct?
I would hope so.
Well, I hope so. But that's what happens.
Sometimes it does, and I like to see more cases where that it does happen. I unfortunately see the bad end of surgeries.
Oh.
A lot of people who have issues after surgery, scar tissue,
Right.
Difficulty with incontinence again, or the sling has failed. I do see that end. It's not all rosy from my end. So I do want to address those as well. So.
Well, I don't think any health professional that provides their knowledgeable and well-trained services can offer 100% on anything.
No.
But the idea is that if you don't have the knowledge of the opportunity, for example, if Dr. Schachar's patient needs your help, at least it's available. Rather than him staying mute and saying, well, that's it. I did my job, but I'm looking at him straight in the eye and I'm saying, I don't think he's the kind of doctor that would do that. So therefore, he might end up referring to you, right?
That'd be great.
And since there are only two of you in Broward County, you work together at Westside Medical Center, that you're right here available for care. Of course, you work at Plantation General also. But I think it's valuable to the people out there that have been asking these questions. So again, folks, I always say to you, you got to take good care of yourself. So you're seeing your general practitioner, your family doctor, your general internist, etc., etc. The females are seeing their gynecologist, the males are seeing their urologist, and you might need this specialty care, which I don't think any of us ever thought that was available, but it is. So here they are, Dr. Jeffrey Schachar and Danielle Marie, both people that are South Floridians, which is not always the case, and they're giving back to their community by their well-trained care. And I always say to you, you've got to tell your doctors when you visit them what's bothering you. I want you to know that we have a telephone number and an address right here. If you have any questions, you have any comments, just let us know. This program comes to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.